So I'd like to introduce our panel moderator today, Maya Feeling, is Director of Operations at the SIVA Teaching Kitchen, which is the home base for the GWU Culinary Medicine program. She's a public health nutrition educator and researcher based here in Washington, D.C. Her areas of focus include nutrition, health promotion, and operations management. She has over 10 years of experience in community outreach as well as hospitality management. Interesting juggling with all those things, so that's fantastic. She is fluent in Spanish. In addition to her work at SIVA, she enjoys startup environments as well as working with well-established programs. Thank you, Maya, for leading the panel discussion. You're welcome.
Go a little bit lower here. Thank you, everyone, for having me. It's a pleasure. As you can imagine, we have many questions to get through today. As you can imagine as well, many of them are surrounding GLP-1s and Ozempic. So I know Dr. Tucker could probably give another hour-long talk on just that subject on its own, but we will do our best to kind of get through everyone's questions. I know we have some Zoom questions coming in to me live, so I will try to get to those as much as possible. But real hot topic, Dr. Mostashari, favorite fruit and vegetable is the first question.
So I kind of think that avocados are considered berries. I did not know that, but actually, to be honest, I just Googled it when they said, kind of like avocados are fruits, right? And then it turns out they're considered berries and like specific types of fruits. So avocados, definitely my favorite kind of fruit. And then in terms of vegetables, just even have tomatoes. Like, it's very simple. It's not very sexy, but you know, it's just tomatoes. Really love them in everything.
Thank you. The people wanted to know. We appreciate it. I will just go ahead and start with Dr. Tucker. We have definitely quite a few questions around Ozempic and the utility, but I will just start with kind of the most culinary medicine appropriate questions regarding the evidence behind the Mediterranean diet and low glycemic index foods, as well as a little bit of a discussion around a whole food plant-based diet and how that has also been shown to allow patients to lose weight, keep it off, and reverse disease. So kind of just some general discussion on the evidence behind those diets.
Okay. So is this on? Can you guys hear me? No? Yeah. Closer? Okay. Hello? All right. Let's just do this. That's better. So in terms of specific diets for weight loss, I teach in our culinary medicine program. I am a big proponent of the Mediterranean diet and Mediterranean diet principles being used across a multitude of heritage diets. That being said, when we are talking about weight loss and the evidence, there really is no evidence for one diet over another. For those that were here earlier in the week when there was a discussion around intermittent fasting, time-restricted eating versus calorie restriction, I think we did a really lovely job with nutrigenomics talking about why a calorie is not a calorie for everybody. But when we're talking about weight loss specifically, the amount of calorie reduction you need might be different for different people based on these genetic epigenetic factors. But at the end of the day, it's going to be some degree of calorie restriction that's going to lead to weight loss. There has been a lot of studies looking into this. I know a lot of people write books promoting their different diets and go on social media promoting their different diets. There has really been no evidence to say one macronutrient profile, one specific type of diet is better for weight loss. Now, again, we can all have a really good and interesting debate on type 2 diabetes prevention, dyslipidemia, different comorbidities and specific diet. But if you're asking me specifically in the weight management world, the diet that works for you is the diet that works. This is what I say to my patients all the time. The diet that you're going to stick with, I'm going to give you some healthy parameters, right? We're going to try to decrease ultra-processed foods. We're going to try to improve fresh food intake and get a good balance of, lean proteins and plant-based foods. But again, what is going to work for you is what is going to work.
Thank you. Kind of segueing off of that, we had definitely a lot of questions regarding long-term use of some of the GLP-1s and medication, as well as long-term maintenance and weight management. So why does the body fight so hard against weight loss maintenance?
Yeah, so that's why I really like to show the brain picture. There are just a lot of compensatory counter-regulatory measures happening in your body that, increasing your hunger drive. When we lose weight, we also have this compensatory decrease in our metabolic rate. Did anyone ever watch the very problematic show, The Biggest Loser? Some people, it's getting older and older in the cultural memory, so people know about this less. There's actually some really interesting studies that came out of contestants that participated in The Biggest Loser and what happened to their, overall resting metabolic rate after weight loss. It goes down when I think, the hope that everyone has is like, I can diet, right? This is why I kind of put our diet in quotes. I can diet for a short amount of time. I'm going to lose the weight, and then I'm going to go back to what I was doing before because now the weight is gone, and now I can just eat the way I was eating at this lower body weight. The answer is you cannot. If you want to lose weight and maintain that weight loss, you need to make lifestyle changes that you can stick with, and you need to be able to maintain those lifestyle changes because the second you return to your previous habits, that weight's going to come right back on. So this is where, things like medications, like bariatric procedures for more durable weight maintenance long-term can be really important because weight maintenance is really hard. Your body has a lot of reasons that it's kind of fighting against weight loss and trying to take you back to that previous, what we call sort of this homeostatic set point, right? Your hypothalamus really wants to like get you back up there and it's going to tell you it's hungry. The other thing that happens when we have large amounts of weight loss, this happens with all weight loss, I want to say, because I've also seen a lot of headlines of, I'm like, I hate these terms, but I'm going to say them because they're in the media, like Ozempic face, right? Like people that are losing a lot of weight and they have a lot of lean muscle mass loss. This happens with all weight loss. If you have, extreme calorie restriction just through diet, if you have it with medications, if you have it with bariatric surgery, your bodies are going to lose muscle mass as well as fat mass. This is why we talk about exercise so much with our patients that are on their weight loss protocols because we really want them to maintain and rebuild that lean muscle mass. But the less lean muscle mass you have also kind of contributes to that metabolic rate, right? So we know that exercise is really one of the best ways to prevent regain after people have lost weight. And so we'll often say, diet and food changes are going to be the first step and really the most impactful in the weight loss phase. Exercise is going to become more and more important in that weight maintenance phase. And again, that's across the board, whether we're talking about diet, medications, or surgery. Did that answer the question?
Absolutely. And kind of piggybacking off of that, are there folks that need to stay on the meds, and what would long-term side effects look like there?
Yeah, I'm hoping nutrigenomics will help us with this one. Honestly, as I sort of mentioned a little bit, I do think there's very different phenotypes. And as we're sort of setting people's expectations, it's really important to say, some patients are going to be able to use these medicines as a tool, as a bridge to get the weight down and to maintain off medications. Other people really have a physiological struggle with that. And it's hard to say. There's not really good guidelines, to be totally honest, on when to stop the medications. Most of the patients that I work with, right, and I work with younger people, our goal is not to be on medicines for the next 50, 60 plus years, right? So we want to be, trying to set that end goal and get off the medication. If we're not able to, we might have to restart. We might use different medications. A lot of people in the obesity medicine space really do talk about it as a chronic disease, the same way that we might have sort of relapsing and remitting, right? We might have a patient with type 2 diabetes that makes lifestyle changes and is able to come off their medications, and then as they age or they go through pregnancy or they have changes across their lifespan, they might need to restart medications. That treatment plan might look different. And it can be the same for people with anti-obesity medicines. So as a kind of quick, I would say kind of quick discussion, I'll usually say we're probably going to be on this for 6 to 12 months. We're going to see where we are in terms of our goals. Where after 12 months, we're going to see if we're in a place where we can wean off. If we're unable to, depending on where your BMI is, what your comorbidities are, maybe we will talk about some of these more durable options in terms of bariatric procedures and surgeries.
So, Dr. Mostashari, how fast would lifestyle changes elicit epigenetic changes that modify disease risk?
Actually do a methylation test and see whether there is an actual change. I would say it would make sense if there's sustained changes that it would be over a year. So it's actually quite fast. So you don't need to do that for 15 years in order to see a change. And so it's one of the best things about lifestyle change is that. The only kind of downside of it is you could also have the reverse change once you give up that lifestyle change. So the epigenetic suppression of a particular gene expression is not forever. It would be amazing if that were the case. If I were to change my lifestyle for 6 weeks, then I would shut down my, craving for carbs. Wouldn't that be amazing? Unfortunately, that doesn't happen.
And can you explain a little bit more as well on how genetic variations can affect your gut microbiome?
Yeah, so there are many, many different ways that happens. So the composition of your microbiome depends on actually what the microbiome consumes, and what it depends on your parents' gut microbiome composition, particularly your mother's gut microbiome composition. That's the baseline from which you start operating. So as a baby, when you're born pretty much with the same microbiome environment that your mother has, and then over time you kind of evolve through your nutrition. Now, there's two things that impact that, and it's hard to decouple them. One is the genetic aspect of it, where you're kind of getting the same microbiome composition through genetics. And the other one is the fact that you're living with the same mother that has the same microbiome composition because of the same nutrition. So your nutrition is also the same. So it's hard to decouple which one is it that is actually driving that microbiome composition. Is it your genetics, or is it the fact that the lifestyle and the environment you're exposed to is the same as that of the genetic parent? So a lot of research needs to be done to see how that actually works, but the mechanisms are actually quite straightforward. In some cases, for FB ratios and other things, we can actually see strong genetic influence.
So you mentioned a lot about family. You gave us some information surrounding, our enslaved ancestors and health implications today. So traumatic and also a bit validating, I think. What would some first steps be when personalizing the interventions for Black people specifically? And kind of a two-part question. Is there data through epigenetics on how generational trauma affects the nutrigenomics as well?
Yeah, so again, as I said, these are emerging areas of study where we're looking at there's an interesting concept of how does intergenerational information get to the next generation. One would be to say there are actually DNA mutations during the time that the parent is alive, and that would change, that would kind of go down. That would be easiest. Unfortunately, we do not see that as often happening as much. But what we do see is the histone modifications that happen because of epigenetic changes during the time of the life of a person can actually be stored, and instead of being erased in the next iteration where the next person is born, those histone modifications continue. So for example, if you have lived in an environment where there was a shortage of food, your body adapts. And how does it adapt? It basically starts expressing genes that store fat more efficiently. Now, you store fat more efficiently because there was a shortage, and you continue to have that intergenerationally, and then you get to a place in today's society where there is ample fat. There's ample on the sugar. So now you're storing it without your body really needing it because it's no longer in those drought conditions or those environmental conditions. So, again, these are hypotheses, working hypotheses. To test them, we require so much more data because it's hard to decouple it from social determinants of health. It's hard to decouple it from so many different factors, but it is enough of a scientific understanding for us to pause and understand that because we do know that there are histone modifications that go intergenerationally, and these are plausible mechanisms that we should look out for them. So we still need a lot. I just want to say one thing with nutrigenomics. If nutrigenomics were to become I don't know, mature at some age, we are probably a toddler in the sense of where we are in the knowledge, right? And as AI becomes more powerful, we will be able to understand a lot more, but that also requires data. So right now, a lot of our problems relate to the fact that we have the need to have, let's say, data from the African American population. Very hard to get genetic data. Why? Well, it's the upper middle class that goes and does the DNA testings for 23andMe and others, right? So we have most of the information that we have. So right now, the US government has started the All of Us project, which now is much more comprehensive. But up to 2 years ago, the data that we had, for example, at LifeNome to process was pretty much 95% white. And that's very disturbing because basically we did not have enough representation. So the less data we have, the less likely are we to be able to make predictions because it's only with data that we can do this.
So transitioning into AI a bit, as you just mentioned, Dr. Piros, love the use of AI is kind of the general feeling here, but it can feel overwhelming for some. So just any general suggestions on how to start?
Yeah, that's a good question. Actually, I was also asked to kindly point out that one of the examples I showed for producing the calorie results, it comes from a lot of the USDA data, which is obviously not the best. So it's a little bit of a garbage in, garbage out. So how to start with AI? I think for people that are interested in the field, there are obviously lots of models and lots of stuff that you can look at. I kind of like actually, the best way probably is to play with, with GPT, for example. You can actually ask it for some recommendations. But for what you guys are probably interested in, the large language models, the best way is probably to start playing with the models themselves. And there's plenty of those online right now you can do that with. In terms of the imaging side, it's a little bit more complicated, but there are quite a few tutorials out there that will give you some in-depth, explanations of how these work. And the truth is that in some cases, the answers aren't really clear, right? We don't know necessarily, there's not always a clear-cut explanation of why a model picks or chooses its result. So the other area I've used a little bit, YouTube has quite a few videos on this. Some of them are obviously super in-depth on the math side, which, again, probably not really what you want to do. I think, building like a simple classifier or something like that where you play with a little bit of Python, that's probably something that is maybe somewhat useful for the research crowd. So that area is probably where I would kind of invest time in. And then the actual building the models, people talk about all these advances. The models right now are pretty good. Like the stuff like ResNet and DenseNet, this is the stuff that's readily available. Are pretty mature, and so I wouldn't necessarily go play around with that. I mean, you can just essentially write a couple lines of code to take some data and run it through and see how it performs. And that's kind of how I approach it. Because I mean, you can spend a lot of time doing that, but it's not necessarily going to change the result a significant amount.
So for folks who are potentially more low-income patients that maybe are not as familiar with using software or apps like that, how can we help them with determining, specifically regarding weight management, how can we help them navigate?
In terms of what apps to use or... Yeah, that's a great question. A lot of them, I think the point here is that basically we're still, as just talking about, we're early in the cycle of this, right? So these apps haven't been out for a long time, and so they're not going to do a great job necessarily of making recommendations for a diet, or for management guidelines. That part of it is still probably don't do. But on the flip side, though, they probably have some utility in helping you summarize stuff. Basically, patients bring all this data maybe or clinical notes. I think that's the area where I view them right now as being helpful. the actual part of giving specific, recommendations or in terms of using specific apps, I think that's probably, I'd still say, put a pause there. I don't think right now we have, great tools that are really outside of the research phase. There are quite a few of these, like the ones that are clinically available, for example, on the AI side. They have stuff that will pick up on bone mineral density from like a chest X-ray or CT. That stuff is legitimately good, and it's fine. But that's kind of where we're at. Like these very simple markers that are basically right now FDA approved and can be used. Whereas some of this more advanced stuff I was showing, it's still a question of what do you do with it and how do you use it. So I think patients ask this, and I think you can say reassuredly take a pause. They're fun to play with, but they're not going to replace us, physicians, clinicians, anytime in the next couple of years.
So we saw some inaccuracies among different populations. Wondering if you can comment a bit on the risks that you mentioned of AI and ChatGPT, either continuing or promoting implicit bias, prejudice,
Absolutely.
and perhaps what work is being done to kind of improve the racial equity for the AI models? Yeah,
absolutely. There is a huge issue with that. I mean, and just to your point, you were saying a second ago, most of the imaging data we get is people that actually have come in for imaging. So there's a whole segment of the population that doesn't get, healthcare really, or doesn't come in to get imaging until they're very sick, or if at all. And so I think that's an important point. The data is basically whatever the model has been trained on, essentially, that's its underlying bias. And so I think the answer is that basically there are efforts being made to obviously create more diverse data sets. That's going to take time. There's a lot of issues with HIPAA and regulation in terms of sharing that data. And so I think, it's not going to happen overnight, but I do believe that these will eventually get more mature and we're going to get bigger and bigger data sets. And there's been a lot of work on that. Like the UK has the biobank, which is very good. I think that's one example. We don't really have a nationalized repository really in a sense. So that's part of the problem we struggle with, that every practice has their own data set. And so that's sort of kind of where we're stuck. That being said, though, the good news is that I think the tools to make these models has gotten much better over the last couple of years, and so I can see a point where maybe you do have an in-house thing you use for your practice or for your system, and that's a possibility. There's this concept of foundational models. So you have a big model that's trained on a whole bunch of different stuff, and then you sort of tweak it for your practice. And I can see that being kind of the path forward to handle some of these inequities and variances that we're seeing.
So, Dr. Tucker, I know health equity is a major pillar of the work that you do. You mentioned some pitfalls early on in your presentation in the utility of BMI and the use of other potentially harmful language, morbidly obese, et cetera. Can you share a bit more about that?
Yes. So I think that anyone working in, whether it's obesity medicine, culinary medicine, or anywhere where people are kind of coming to talk about food and advice around weight and potentially weight-related or diet-related health conditions, is really important to be careful about your language and to, again, recognize that people have felt really stigmatized in healthcare. There is a movement called Health at Every Size that I would imagine some people in this room have heard of, and it exists for a reason. It exists because people have really felt that their healthcare providers have judged them, and based on the things that people tell me they have been told in the healthcare setting, they have been judged. Dr. Kofi Essel and I run an obesity summit at GW Medical School where we do a weight bias assessment with the medical students, and they're able to submit some anonymous responses. And it is getting better, but not as quickly as I would like. Some of the things that, the assumptions made that obesity is solely because of people eating poor diets, not being educated. And we have learned, so much, and especially for those of you who've come to this conference just in the past 3 days, right? The variety of influences of our genetics and our epigenetics and our lived experiences and food insecurity. And so I think that is why I didn't get to finish my presentation, because I like to caveat everything I say, because I think those caveats are really, really important. But I also think we can have the tools to have that empathetic language, right? I say obesity is a clinical diagnosis, and that's why I mention it, that it's what we have. BMI is kind of the best and easiest tool that we have. If anyone's going to the American Academy of Pediatrics conference, I'm going to give a whole talk on my feelings about BMI. So you're welcome to come there. But it's what we have, and it's what's going to be on the chart. I don't use that word with patients because I recognize that in our society, it's a really loaded word. I would never tell anyone that you have obesity and we're treating XYZ, right? We use much more neutral terminology typically in clinic and talk about, some weight-related comorbidities. We might talk about those comorbidities specifically in the absence of even mentioning weight. We might kind of look at the growth charts and the BMI in terms of trends in their numbers, as opposed to calling out like one specific point in time, which can be difficult. I also recognize, as we were talking about weight loss, right? I have patients on the extremes, and I have young adults that I have to transition. And for some of my patients that have reduced their BMI from 50 to 35, I tell them they are perfect where they are. You're going to go out and see other doctors. If somebody doesn't ask you your history, doesn't look at your chart, doesn't use the right language when they're kind of looking at your vital signs, go find another doctor, right? I don't want you walking in and someone just saying, hey, you have obesity, let's talk about this, let's do this. We all need to pause, we need to ask our patients questions. And I think the tricky thing that I have debated with some people in the health at every size movement is, like everything, if we're on too far of an extreme, then we all kind of lose the thread a little bit. There is a point where we do have to talk about weight, and we have to, again, have these tools, the physiology, the genetics, the understanding to talk about it in an empathetic way, but we have to be able to talk about it, and people are often grateful to talk about it. I have parents that are in the room as I'm talking to their kids and their teens saying, can I come here? Can I use some of these medicines? How come my doctor never told me that these exist? I've never even heard of this. Because we're not talking about it and people want to hear about it. So I think that it is a balance, but I appreciate you guys all being here, right? Because that's why we're all here, to educate ourselves and to be able to have these tough conversations.
So I love that you also mentioned in your presentation asking permission to talk about weight. I think, you've kind of told us a bit about how you landed there as a best practice, but perhaps some guidance on strategies for when they say no and places to start for when they say yes.
So if they say no, right? So that I would say I respect. Now, there are very rare, unique cases that I think probably most people in the room may not encounter. Some of you might. I sometimes do, right? So certain disease states, sometimes I'll go in the hospital to consult on patients that have, idiopathic intracranial hypertension, I think is a great example, or what used to be called pseudotumor cerebri, if some people are familiar with that. You have increased pressure in the cerebrospinal fluid. It can affect your optic nerve. People can have blindness. Rapid weight loss is an important component of treatment to reduce that CSF pressure. And I have, had uncomfortable conversations to sit down with patients that say, I don't want to lose weight. I don't want to do any of that. And we have to say, I know you don't know me. You don't know that I normally would not have this conversation if you don't want to have this conversation, but we have to have this conversation, right? These are really unique circumstances for the most part. This is why I said in the talk, there's plenty of other stuff to talk about, right? And there's plenty of other things that we can impact people's health through diet, through culinary medicine, right? So if it's something that has come up where someone may have, a diet-related comorbidity, you're concerned that their weight's impacting it, but there's still plenty of other avenues, I think, to discuss healthy lifestyle factors without focusing on that number, because that number has just been made to stress people out so much.
So we had quite a few questions on sort of special populations when it comes to weight loss medications, specifically pre-diabetics, folks with eating disorders, folks with developmental disabilities, and also just younger adolescents. Just sharing any thoughts on best practices there. I know that's a long
Those
question.
are very broad. Yeah, and I'll hang out after if people have like very specific questions. What I would say though, as a pediatrician, is I don't think my view is honestly, ethically, if we know that we have medications and treatments that can help people, I don't think their age, I don't think their cognitive ability should be a barrier to that. We have these evidence-based treatments. Those of us that are prescribers go to, medical school or have our NP license for a reason, that we should be able to understand the physiology, and we can have conversations with patients. As mentioned, I've been doing this for 10 years now. When I first started, there was really very little that was FDA approved for younger patients. And so we would have off-label conversations over and over. And a lot of, I would say, these unique populations, what we're often seeing is really behavioral components going in that are driving overeating behaviors, right? And some of the things that my colleagues have talked about with those sort of epigenetic drivers, difficulty recognizing satiety. And there's medicines both on label and off label that are really good at that. As a pediatrician, we know that there are patients with ADHD that have extreme impulsive eating behaviors. Parents tell me the pantry is raided, and just managing that child's ADHD, right? And it is a stimulant oftentimes, and they do have some degree of appetite suppression in themselves, but just managing that child's ADHD or maybe whatever kind of behavioral comorbidity might be going on, and those eating behaviors drop. And again, once that food seeking is decreased, then it becomes so much easier to implement these lifestyle changes. And so that's, I think, the biggest thing that I would emphasize too, is that these medicines are tools to be done in conjunction with lifestyle. And for parents, particularly of younger kids, that's one of the things I hear all the time, is that it's not that, especially kids maybe with special needs, maybe on the autism spectrum, it's not that they don't want to feed their child healthy foods, but they've got so many other things to deal with. And maybe that food is a reward for a positive behavior. Maybe it's just not worth another fight to try to, change their child's diet, or to tell them they can't have that extra snack if they know that it's going to induce a meltdown. And just like turning down that hunger dial for that kid makes the stress level in the whole house go down. I cannot tell you the number of kids with autism or sensory needs or some behavioral challenges that we've been able to use a variety of on and off label medicines that function as appetite suppressants, and the parents come back and are like, everything is calmer, everyone is happier, because that drive to overeat is really extreme, and it really ends up taking up a lot of people's lives. So there are, I think, definitely places in some of these special needs populations that we don't want to withhold treatment.
So as we're kind of discussing tools for clinicians, Dr. Piros, what would a typical runway be for implementing AI tools in clinical applications?
Yeah, that's a good question. I mean, so we're all struggling with the idea of how do we get these actually into practice. I think Epic has done a good job on the LLM side. So if you guys are using Epic in-house, undoubtedly you have someone that deals with it. Talk to them directly. It's probably the easiest way at this point for many of these applications. We're going to see the problem ends up being, which I think I pointed out at the end, is, you have all this extra data now, maybe biomarkers, whatever it is. How do you really, implement that into practice? And, there's not really, a lot to go off in that sense. We're in the cases in the adult populations, for example, like I pointed out before, bone mineral density or, vascular disease, obviously there are some guidelines to basically deal with that. But for the body composition stuff, we don't really have a lot, I think, in terms of data of how to approach that. And I think, as hopefully we get more information with the GLPs, we can see how we can sort of integrate these maybe into specific recommendations. My dream is that basically, we have these tools integrated, and then we basically have essentially, best next steps possibly based off of, what the data is for this person. So we want really personalized recommendations, right? So, things like, metformin versus whatever other treatment option, what's the best choice in this scenario? So the problem with that is that those data sets are still kind of in progress as we speak. So LLMs definitely Epic. For other biomarkers, there are ways just to do it through Epic as well. There's a Cognito platform they have integrate these markers in there. But I think the question is, what do you do with them? And that's still, I think, up in the air.
So kind of along those lines, how far are we from having AI included in EMR for diagnosis and especially for complex medical patients?
Yeah. One of the points I would make out, so when we did the study for the chest x-rays and the diabetes detection, most of those patients had BMIs that would have qualified them for just getting an A1C. So in many cases, they would have just been basically, they should have got screening. We just didn't do it soon enough. The big question is, would you change your management based off of this? So if the AI says that I think this person has a high risk of diabetes, are we worried that they're going to have, complications? And so one of the things we've looked at specifically is end-stage kidney disease. And, these models actually can pick up on these changes that we can see. So some of the dreaded complications of diabetes. So the question then becomes like, great, you got this information. Do you then basically do a more aggressive approach with that patient? But to go back to what your point was, currently the way we've been doing, some of these have been integrated into radiology reports. And so basically sometimes reports will have some mention. One example I was saying before was like the calcium scoring, if someone gets a routine CT scan, that calcium score will be included. And that's really kind of an indication that maybe they should get a lipid profile and some additional workup as well. As far as beyond that, right now that's where we're at. So there isn't really like, one of my colleagues talks about like, can we have it where basically the AI does sort of a summary and recommend, you have like an AI generated summary and recommendation system. And I think we don't have that data yet. And so probably all of his recommendations or summaries in that sense would be wrong.
So switching gears just a little, perhaps a less sexy conversation on insurance for a moment for all three of the participants. Dr. Pierce, I will start with you since we have a bit more of a specific question. How is AI being used for prior authorizations and insurance companies?
That's hysterical. I just had a conversation about this last week. Yeah. It is being used. So right now I've seen a couple companies that are making essentially like for the prior auth stuff, they're trying to make basically these models so they can essentially extract relevant information. So, like basically when the prior auths, a lot of times it's a web page that you have to go through for the insurance company. It's a big pain in the butt. It's really a waste of time for a lot of people. We have staff that that's all they do, right? And really a lot of times you're just copying and pasting information that you have in the EMR. So there's kind of a gap there. So I think those language models could do a lot of that kind of scut work of just retrieving information that you need to put into for the insurer to have for prior auth. So I think that is happening as we speak. We're seeing companies are actively working on it because we know it's a huge pain point, and it takes a lot of time and effort and energy. The issue that I wonder is like how long, and we know that the insurance companies are using AI on their side, so it's going to be basically a back and forth where you're fighting with the different chatbots. It may be at some point, it's like it's going to be this whole circle. But I think for that aspect, yeah, I think it's very helpful because we have patients, every practice, you have a big practice, literally you're dealing with thousands of different plans, right? It's not just simply the insurer, but each sub-plan the insurer has. So that aspect, I think the filling out of the forms, I think could be greatly helped by the language model side for sure.
Dr. Mostashari, any thoughts on accessible nutrigenomics testing or how insurance may play a role in this in the future? And I'm being asked if you can speak a little bit closer into your mic as well.
Absolutely. My apologies for speaking probably on the lower volume. Right now, not on the side of claims, but on the side of lifestyle improvements, insurance companies want to generally reward people for kind of improving their health. It's very hard for them to justify that. Their stakeholders that they're paying this money for prevention. So it's much easier to pay for a person's procedures than to pay for prevention because prevention is hard to, what do you kind of compare it with in that sense? The person's not sick, so you didn't spend the money, but you don't know how much you would have spent if they were sick. So right now, AI-powered tools allow us to predict how much you would have spent if the person did not change their lifestyle. So, for example, we have developed a longevity and basically morbidity model, the longevity and vitality model, which is the morbidity and mortality model, that allows you to see how much with large-scale data sets with more than 1,000 biomarkers, how a change in a person's activity, the nutrition, sleep, and stress management over time will impact their lifespan and their health span statistically. which then is connected to their actuarial table and life tables by which they determine the value of things. So this wasn't possible before. Why? Because if you were to do this using basic statistics and you held one thing constant and you wanted to change everything else, it would require more than the population of Earth in terms of data sets to be able to do that, whereas now you can take into consideration many changes at the same time. So you don't have to hold one thing constant, given everything else constant. How does 10,000 steps change things? People don't live that way. I might increase my steps to 10,000 steps and then eat tiramisu. How do they cancel each other out? What happens there, right? And AI allows us to actually take everything into consideration at the same time and still provide a much better picture so that when people do improve their lifestyles, that they can get benefits from that. And the insurance companies can justify that because, let's be frank, they care about dollars more than your health.
So Dr. Tucker, in the insurance kind of realm of things, in order to get obesity medications covered by insurance, the question is, are there requirements to do a certain amount of lifestyle modification first?
Yeah, this is probably a whole other talk in itself. I'm going to jump back to the last question real quick because I did remit the sort of eating disorder population question. One plug I want to make, I think as important as it is to screen for restrictive eating and purging, also make sure to, question about binge eating in isolation without purging. Binge eating disorder is hugely underdiagnosed and is treatable. There's really good models for eating disorder treatment of binge eating disorder. It also does respond quite well to adjunct pharmacotherapy along with cognitive behavioral therapy. 5-ounce lisdexamfetamine is FDA approved for adults over 18 with binge eating disorder. So that's my little plug there. Insurance. I spend a lot of time with insurance and talking to providers at my institution. And I think honestly, sometimes this is just even why I get referrals, is because people don't have the time and energy to deal with insurance prior authorizations. And they're like, go to that multidisciplinary clinic. They have more resources. And we do. So I think it sometimes is just a bit of a time and energy commitment. In terms of medications, there's usually not a sort of pre-medication requirement for lifestyle therapy, but most insurers that are requiring prior authorizations, there will be questions as to whether the patient is participating in an active weight loss with lifestyle component program in conjunction with the medication. Insurance really, unfortunately, does determine a lot of the choices that we make around medication prescription because particularly when we're talking about GLP-1s, right? So our semaglutide, our liraglutide, these are expensive medicines. They are not something that I would ever ask people to pay for out of pocket. I will generally say that, I just want you to know it is an option. Just because your insurance doesn't cover it doesn't mean you can't get it. It just means they won't pay for it. I would never ask someone to do that, but I do feel like, people also need to know that. And the same thing with the oral medications. And so most of our oral medications might be affordable to some people out of pocket. So that's an option as well. Right now in the US, I think, and I had a policy conference recently, about 30% of commercial insurers exclude obesity medicine coverage from their plans. There's sort of a whole category, right? And so this is sometimes the frustrating conversation where patients will say, oh, this isn't covered. Can you send in this? I'm like, no, if this isn't covered, this isn't going to be covered. This probably just means your entire plan excludes obesity medicine benefits, which can be really frustrating. And then we can sort of have other discussions around patient benefit services, which can be available online, what coupons look like. What I will say in the semaglutide landscape, which is, because I know these things are out there, I do not recommend, at least personally for my patients, that they ever use a compounding pharmacy. A lot of compounding pharmacies have popped up to make semaglutide. It is patented. I don't know exactly what they're making. No, thank you. That's at least not coming from my prescription. If you go elsewhere, that's your prerogative. But I have some concerns around some of the compounding pharmacies that are trying to replicate semaglutide. That being said, it is available globally for much cheaper than it is in the US. And so I have some patients with dual citizenship. I have a family that's Egyptian, and they stock up on their medication for 6 months at a time every time they go back home to visit. And that I'm happy to write a prescription because it's coming from a legitimate pharmacy that's giving them, semaglutide made by the drug company. So there's, some other ways around it. Things are getting a little better. I've heard, people say, well, Medicaid doesn't cover any of these. Medicaid does, but it is up to your state to kind of choose how they apply that rule. But technically, Medicaid does offer the option to cover these medications with a weight-related comorbidity. Obviously, it is always going to include a prior authorization, sometimes an extra appeal, and that also comes down to time and energy. In the DMV, right, we essentially have 3 states, so I get to be in Virginia and DC and Maryland. So it's interesting to me that I even see how this is within our region, kind of allocated differently across these different states. And I'm sure you guys are coming from all over, are more familiar with your states than I am. But it's not that they're not allowed. And so just be familiar with what your state Medicaid allows if you see Medicaid patients, what your regional commercial plans often offer. Federal plans do cover this. Federal plans all are required to cover anti-obesity medications. So a lot of times people can access them. It's just that we're not discussing it or offering it at nearly the rates that we could be.
So I know we talk a lot about using kind of a yes and approach for lifestyle modifications in addition to, medications, AI, genetic testing. This question was specifically for you, Dr. Mostashari, but I think I'd love to hear everyone's perspective on how you think the use of each of your particular professions and tools could kind of allow some patients to, quote, give up easily on the lifestyle changes because of the use of the tools that are being offered.
That's a very good question. So what we've noticed is people get personalized recommendations. They're much more likely to follow through with programs than when they get general recommendations. So when we're able to actually tell a person, here's the specific things that are good for you, and this is for Jane or John, or it's not like for the generic population, there are a limited number of things that our willpower allows us to do. If you tell someone, here's 110 things you can do to improve your life, people are not going to do it. But if you tell them, for you, the most effective seems to be these 3 things, people could wrap their head around it and they could stay longer. Our research showed, we did a pilot in Latin America where we tested 1,000 people, where 500 of them got more general health recommendations and 500 got personalized recommendations that were informed through genetics. And there was a 68% higher retention rate over 6 months with regards to the lifestyle program for people who had gotten those personalized recommendations than people who didn't. And there are 2 aspects to this. One is the psychological placebo effect. I just like things to be more personalized to me. But we need to take that in consideration. But the second one is also that it's much more effective for them and they actually feel the effectiveness over time. So personalization, again, is one way of keeping lifestyle change retention higher, both through the fact that something is personalized, they feel attention to it, the fact that they've gone through the process of personalizing something for themselves is an investment. That is actually a first step. So that helps. And then the other one is the actual increased effectiveness. The combination of the 2 is very powerful.
Yeah, so from the AI biomarker side, I think the big opportunity here is that to identify patients that don't actually come in. So that's the big problem we see, that a lot of patients obviously don't seek help. Maybe they're afraid or, the issues of cost of care. And I think, basically when we do have this opportunity, they come in, we have information, we could say, look, you have a high risk profile based on these imaging biomarkers, let's bring you in. I think this triage system, I think that's a very strong use case for these AI tools. And, not to make the diagnosis, but to maybe get you to the right place, see the right person, to get more intervention. And then as far as the personalization stuff, I remember on The Biggest Loser, they actually did have this, kind of shtick where they would have them do an MRI scan and they would show them the visceral fat and they would do some measurements. That's, I think, very helpful because patients can understand. They could see that's where the fat is and this is what's going to change over time. Now, the problem is MRIs are not cheap, and we're not going to tell patients to get CTs just to get it for fun because it's radiation. So that's a limited thing, but I think it's powerful when you have that information to see, I can see inside, I can see what's going on, and here's the weight loss, here's what's changed. And so I think it's definitely beneficial from a psychological standpoint, undoubtedly, but unfortunately probably not going to be something we're going to do on every patient. Maybe there are other tools out there, a lot of these tools that use like LiDAR cameras and lasers to do measurements and body habitus stuff. So that stuff is actually you can get on your phone. It may have some role in letting patients kind of see what's going on and how things are going to change. But the triage point is, I think, something that we're seeing already a lot in radiology, even where the AI is trying to look and pick up on acute findings. And so I think that's something we can see on a bigger systematic level where we can use it to triage and say this patient really has like a high cardiometabolic risk score. Let's bring them in and get them seen. Because oftentimes when they do show up, they're already well beyond the point of getting easily helped at that point.
Yeah, so I have so many examples. And I really do feel like it helps people make these lifestyle modifications, and it is a this and not a this or. It is a lifestyle plus, not a throwing medications at people. And these can be really helpful tools to give, kind of a specific culinary medicine example to this audience. I have a young adult who I see who lives in Southeast DC. I go there once a week, which is a predominantly African-American, lower socioeconomic neighborhood that I would say is the food swamp that we were hearing about yesterday. And this is a patient that we started treatment with Wegovy. And she came back, just even 4 weeks later for a follow-up and said, like, this is amazing. I could not get from like school to home without having to go in the KFC or in the Popeyes. Like, it's just this constant stimulus. Just like, I was so hungry all the time. I couldn't make it. I know I kept coming here and talking to the dietitian, but I wasn't doing anything that she was saying because I just like couldn't get home without going in one of these stores. She's like, now I can go home. She's like, I can walk home. I can make dinner. Now, like that she's showing me pictures of these recipes, and she was so proud because she could actually get home without being so constantly hungry, and now pull out all the things that the dietitian had given her for months prior that she couldn't do because she just couldn't make it past that swamp of ultra-processed food, and was then able to actually follow the recommendations. So this is definitely a this and thing for me.
So we are nearing the end of this session. I want to make sure I'm asking one of the most burning questions. Dr. Mostashari, what test do you recommend?
So there's a conflict of interest because I represent a company, so I don't want to recommend our test. But in general, any genotyping test is cheaper, on the cheaper side, and more accessible to patients. And genotyping tests are less than $100. And there are many companies that are providing it. And most companies, unless you see, right now everyone can tell if there's over marketing on some website, just skip those. And other than that, just go look and see what the offerings are for those kinds of genotyping-based nutrigenomics tests. And you can then basically provide yourself or your patient with insights based on that. And they do differ in terms of quality and kind of analysis and everything. But I think all of them are more or less on the same page of providing you with very useful information. So unfortunately, I cannot name commercial names right now. Both because of the conflict of interest of me representing a company, but also I don't want to be advertising other companies either. Like, it's just a commercial thing. So I would just say go in that direction of exploring the area, learning about nutrigenomics, and being able to offer whatever makes sense for your patient, regardless of that.
So in our last minute or so, I would just like to ask if there is any question for all three that you are most tired of hearing from people, and what would you like to say about it to never have to answer that question again? Dr. Tucker, would you like to start?
It is fascinating. No, I have been doing this since 2014. Nobody cared what I did, right? Like you would sort of, I do pediatric obesity medicine. Okay. In 2023, the pediatric obesity guidelines came out. Ozempic's on the news. NPR's calling. NBC's calling. Dinner parties. People are like, "Do you prescribe Ozempic?" Ozempic is for type 2 diabetes. Wegovy is FDA approved for the weight loss indication. I just would love to talk less about Ozempic. That is all. But I am happy to answer questions about it in the clinical space if anyone has questions after this talk.
Yeah, for me, it's AI is going to take my job. No, and it's like I think everyone's convinced probably it's not going to take your job at this point. It's just a good, helpful tool. I think the stuff it's doing, it's not perfect, but I think there are some very strong use cases. And for us, I mean, I know clinically on the clinical side, the practice is out of control. I mean, the demand is just really high, and I think probably this isn't across the board. I hear from all my colleagues that we're getting swamped, right? And so it's how do you manage like these high workloads? And I think these tools will probably hopefully lessen some of the burden. Although people have complained that maybe it'll make it worse. Right now, you have all these new things to deal with. But the big thing is like, is it going to take my job? Like, no, it's not going to take your job. Don't quit. Hopefully life will be a little bit better, and these things will kind of make your clinical practice just, not as frustrating, especially on the insurance side and some of these other use cases, documentation, where I think the tools will be nice.
I don't think I ever get really frustrated with any question, except for the last time I remember, I had doctoral students for whom I had an assignment to do research, very interesting research that I found fascinating. I asked them whether for a complex system they want to model the rise and fall of the Soviet Union or the stock market or whatever, and they said, well, which one's the easiest? And that was really like a turnoff with regards to like what's the easiest. And so that was the last time I remember. That's 15 years ago when I got annoyed by a question. Also, like, what's the margin on the report that we're going to produce after I'm very passionate about telling them, there's amazing things you're going to learn. But really, no question I find really kind of have not found them to be frustrating in any way. And most of the time when people ask questions, I learn a lot by providing response.
Thank you for that. It is now 12:02, so I will wrap things up. We really appreciate all of your expertise. There were a lot of questions I wasn't able to get to, so I imagine folks will be around for a little bit after to hopefully answer some questions there. But thank you all very much.
Thank you.
Thank you.
Again, thank you again to the morning presenters very much, and thank you, Maya, for leading the panel discussion. Just some few announcements as we close the conference. Lunch is not provided today. The optional hands-on class will be held at the same Culinary Arts building where we had our previous classes, and that begins at 1 o'clock. So those of you that are participating in that, that's where that location will be, and you'll be in for a treat, as I did that on Thursday, and it's a lot of fun. In closing, I do want to thank the entire team here at Prince George's Community College, specifically Norman Lee, Julianne Hawk, Cheryl Ann Gross, Daniel Kennedy, Megan Anderson, Jordan Holden, Norella Jackson, Marvin Palmer, Maurice Embrack, Lawrence Fletcher, Harry Sermanius, and Thomas Banjett. Thank you for all the teamwork. I hope that was an enjoyable opportunity for all of you. And lastly, I'd like to say all of us here at the conference, especially those of us that work with the American College of Culinary Medicine, we hope that you found this conference valuable. We hope that you are more confident now in applying the knowledge that you learned to the care of your patients and your clients. See you in 2025. Safe travels and good health. Bye, everyone.